Well, hello, everyone. I'm just giving another minute or two for all of our attendees to be able to log in and enjoy this webinar. We are so glad you could join us this evening. And on behalf of ORNAO, thank you for taking the time out of your busy schedules to be here with us. We know how hard everybody is working and how short-staffed everybody is, it seems, nowadays. We truly appreciate your interest in exploring Medline's sponsored event tonight. I'm so excited to introduce Aline Titizian. I hope I did that properly. I tried. And Aline has joined Medline Canada in April of 2022 and has almost 30 years of perioperative nursing experience. During her tenure in the OR, Aline has held a number of roles such as staff nurse, practice leader, interim educator, and clinical support nurse. I'm really looking forward to the presentation this evening. She was also involved in a number of quality improvement initiatives and policy development. We were chatting just before I started the webinar, and she also shared with me that she's done an ORNAO Advanced Nursing Practice Fellowship. So kudos to you, Aline. After the presentation, there will be a live Q&A. So please feel free to drop your questions in the chat or drop them down, and we can certainly have some discussion at the end. We'd love to hear from you. With that, I'm delighted to hand it over to Aline as our speaker this evening. Please join me in giving a warm welcome, and on behalf of everyone from Medline, who we're so thrilled were able to sponsor us, and ORNAO, we want to express our heartfelt gratitude for the incredible work that you do every day. And thank you, and enjoy the presentation. I'm going to hand that over to you now.
Thank you for the introduction, Denise. Good evening, everyone, and thank you for taking the time to join this webinar. This evening's presentation will focus on surgical gloves and why your hands truly matter. As OR nurses, we are used to grabbing what's on the glove shelf and wear it, no question asked. As long as they're comfortable, we're good. Your hands are at the center of everything you do. So let's dive into how surgical gloves can support your vital work and ensure highest standards of care. To give you a roadmap for tonight's discussion, here's what we'll be covering. We'll talk about the evolution of surgical gloves, market trends, and then delve into more specialties with surgical gloves, clinical initiatives in terms of chemoprotection, latex, double gloving, as well as radiation protection. So we'll start with the evolution of surgical gloves. In the beginning, as most of nurses from my era know, it was mostly latex powdered surgical gloves. Over time, when powder deemed harmful for patients and healthcare workers, market needs and trends shifted away from powdered surgical gloves. At the same time, latex allergies started to rise. Around 1999, Medline launched the first polyisoprene glove in the world, which addressed both the powder piece because it's made without powder, as well as the latex allergies because it's the first synthetic glove that's similar to latex without the latex protein. So it gives the fit and the feel of latex without the risks. We also recognize that hand hygiene was a concern. That's why AlloTouch technology was launched. The inside of the glove is coated with aloe vera, and over time, the body heat will help the moisturization process to start. The idea was to reduce dry or cracked hands, which is known to lead to low hand hygiene rates. Over time, and in response to market needs, new gloves have been launched to address the radiation concerns as well as the chemical accelerator concern. The most common specialties in the glove industry are general surgery, micro, ortho, and underglove for indicator, perforation indicator options. Latex powder-free gloves, which have been in the market for a while, are considered good option. And it can be an economical option, but has declined over the years because even though it does not have powder, it is still latex. The better option is the polychloroprene neoprene gloves. This is considered an economical option to go latex-free. So while it's great economic option, great for chemo and chemical breakthrough times, it can be seen as a little bit stiffer, not the same fit and feel as latex. So the best option comes down to polyisoprene, where you can get the fit and the feel of latex without the latex protein. And that's where we've seen a lot of growth. So what can you expect from your gloves? You want them to feel and fit great. You want them to be comfortable. You want them to be strong, like so strength. You want to have latex-free option, and you want them to be easy to double glove, especially that we're seeing more and more clinicians, scrub nurses, surgeons double gloving. Chemoprotection, you might say we don't prepare chemo drugs in the OR except in ophthalmology, but I want you to think about all the oncology cases you've done. A number of patients are operated within 48 hours of their chemo treatment. How do you think staff on the unit handle their blood and body fluid? The OR is no different. The type of patient care we provide in the OR might be different, but the safety measures shouldn't be. Every hospital has a policy that outlines the do's and don'ts. So before scrubbing in the next radical prostate or Whipple for 4 to 6 hours, ask yourself the question, has my patient received chemo before surgery? And if the answer is yes, ask again, how will my gloves protect me from their blood and body fluid? The standard is for chemotherapy testing to have at least 9 covered, but actually there's more chemo drugs in the market. So Medline does test up to 24 drugs. For permeation and breakthrough resistance, like I said before, there's 9 required. On this slide, the bullet points on one side are the 7 that should be tested and 2 drugs of choice. So companies that are going to test for chemotherapy, they have to test the 7 that are on the left side, and they can choose 2 of their choice. This is just a demonstration of the list of chemotherapy drugs that we test at Medline for our product line. They all fall in different buckets of chemo drugs, but the whole point is to make sure we capture more of the market needs. That's why we test above and beyond. So this list, for example, is found in every glove box. For those of you who use Epic as electronic health record, this slide will seem familiar to you. So this is just an example. Every health record in every hospital is different, but the most commonly used is Epic. That's why I chose to show Epic. And when you access a patient's chart on Epic, a message will pop indicating that the patient had received hazardous or cytotoxic drugs in the last 48 hours. So when you see that message, you can go to the MAR, check the medication, and then check your gloves. Which glove will provide you the best or the longest breakthrough time, and you can check the gloves accordingly. If this is not available, if Epic, you don't have the service in Epic or in your electronic health record, any case that might be potentially an oncology case, you could go to the MAR and check if the patient received any medication, any chemo treatment in the last 48 hours. We're going to move to the microbial transmission, and this is where double gloving and glove changing times become critical. So wearing 2 pairs of gloves helps reduce the risk of exposure to blood and body fluid. It is recommended by ORNAO, AORN, CDC, the American Academy of Orthopedic Surgeons, the American College of Surgeons, the Association of Surgical Technologists. Basically, everybody's on board. Double gloving is best practice. Furthermore, wearing a perforation indicator glove improves the detection of perforation. So when we talk about indicator, perforation indicator is wearing an underglove that's contrasting the white or off-white glove. So if you look at this slide, it shows shocking numbers. 80% of all surgical glove perforation go unnoticed. It is shocking. It means 8 out of 10 times you scrubbed, there was a perforation in your gloves. It also means that surgical team members wearing single pair of gloves have been exposed to blood and body fluid 80% of the time. Even though we don't see the perforation, it's there. Another study has shown that 84% of the perforations were noticed when wearing a contrasting color underglove. That's why Medline has a strong See Green for Safety program. See green, change your glove. If you wear a perforation indicator glove, you know what I'm talking about. It's actually very obvious when there is a perforation. So this is a visual. One side has, we have double gloving with same color glove, which is what I've seen in most hospitals I've been to, and I've been to a lot of ORs lately in the past 3 years, I can say. So you can hardly notice the actual perforation. And then on the other side, we have an indicator glove where the perforation is very easily detected. This table was shared at the ORNAO webinar on June 17th. One would say it's not feasible to follow the timing, and I can't agree more. However, what can be done is to always double glove with an indicator glove and have a standardized time in which you change your gloves. For example, there's an agreement, there's an understanding. Before clamping the vessels, everybody will change their gloves, or after dissection. So it might not be exactly 60 minutes or 90 minutes or 120 minutes, but at least there is a schedule. So how many of us have scrubbed for 3, 4, 5 hour long open abdominal cases without changing gloves? Maybe it's not possible to change every hour as suggested in this table, but it is possible to set a realistic plan. So this is in addition to ORNAC's recommendations on when surgical gloves should be changed. So it's not replacing the recommendations, but it's in addition to it. Some examples of when to change is if your gloves are contaminated or you suspect that they're contaminated before handling implants, before abdominal closure, especially that with the new ORNAC recommendations, there's a section about clean closure and what to do and how to do clean closure for bowel cases. For latex now. So we do know that there's a trend to move away from latex due to the allergies that can develop over time. But I understand and I know that not all the ORs are moving away for many reasons. But nurses can be the patient's advocate and are the patient's advocate but I would like to see more advocacy towards self-care. So we're going to see later that the more exposed you are, the higher the risk of getting a latex allergy. So when we talk about latex, we should think of first, it's not by a sequence of importance. I'm just going to start with the staff health implication. So as you can see on the slide, 17% of healthcare workers exposed to latex might become allergic to latex compared to only 1% of the general public. The second implication is the patient health and safety. And there is an increased risk of latex allergy with repeated exposure. So patients who come back to the OR for surgery over and over throughout the years have a higher risk to develop a latex allergy. And the third implication is the financial implication. To treat employees' latex allergies and the cost of OR breakdowns. So let's take a minute and think of a case where the setup of an ORIF is done using a loaner set, implant set with latex gloves. Then the circulating nurse goes and assesses the patient, who mentions, by the way, that they get hives around their lips every time they eat kiwi. And it's like the light bulbs is like, we ask ourselves, we know that there is a link, a correlation between kiwi and latex reactions. What's the next course of action? Here are 3 scenarios. So we know that the whole setup needs to change, but the 3 scenarios that I can think of is 1, change the setup, get a second loaner set, delay the case, but at the end, the case is done safely. The second scenario could be change your setup. I mean, the table covers, suction, sponges. Delay the case, flash sterilize the loaner set, which is, by the way, against best practice. Even though I know that there are some ORs who do it, they run the quick or fast biological indicator, but it's still not best practice. But that's the second scenario. Again, I want to repeat and emphasize that it's not best practice. Or third scenario, if we don't have a second loaner set and we don't want to flash sterilize, we don't have another option. The case will be canceled. So one other thing I want to add is that a study has shown in the States that OR breakdowns could cost up to $3,000 US. So how do we ensure that there are no latex allergies or concerns in our ORs? The best way is to go entirely latex-free, as many ORs have done so far. And as I said in the beginning, we're seeing more growth in latex-free gloves. Polyisoprene and polychloroprene gloves are your options. Polyisoprene feels and fits like latex, so you won't have complaining surgeons. And to be fair to them, gloves are like second skin to them. They have to feel comfortable to be able to perform properly and do the surgery. So they need to have gloves that feel comfortable. And because polyisoprene has the same fit and feel as latex, so it's a good transition. Now, with radiation protection, Medline is one of the few companies that have a radiation protection glove. And to be honest, until I joined Medline, I didn't know there was such thing. So during procedures where X-ray is used, urology, ortho, IR cases, etc., radiation protection is key. We all see the surgical team or in the OR, staff wear thyroid protection, lead apron, but then why not wear gloves that protect their hands? A study has shown that only 5% of orthopedic surgeons said they use radiation protective gloves. SensiCare Shield is the Medline brand of radiation attenuation gloves. It's made with polyisoprene, so it's latex-free. It's also made without certain chemical accelerators like MBT. It is made with tungsten instead of lead, which is less toxic and more environmentally friendly. I just want to mention here that these are not considered surgical gloves. They can't be worn as standalone gloves, and they haven't been tested for hazardous and cytotoxic drugs, so permeation breakthrough time. So I'm moving to my last slide. I want to end this presentation with a quote from Florence Nightingale. I attribute my success to this. I never gave or took any excuse. So I thought, how does it apply to my practice as an OR nurse? And I thought, as OR nurses, we tend to always put patient safety before our own. We give excuses such as, it's not the right time to change my gloves. However, we talked about it, how we can schedule or set a realistic plan and change our gloves without compromising patient care. Or we take excuses such as, oh, latex gloves are the only options in our OR. But again, advocate for yourselves. And there are options. There are latex-free options. There are economical options. And the polyisoprene is like the best option where it feels really like latex without the risk. So I want you to take this quote with you as food for thoughts and think of all the circumstances that in your practice you gave an excuse, but you knew deep down that we can do better, and or took excuses where yes, we can improve. We can always improve, but it needs to be realistic and applicable and possible. And with all the challenges in the healthcare, the budget issues, the shortage, I understand that there are obstacles, but it's always good to have a plan, even if it's a long-term plan, at least it's there. And, step by step, baby steps, you can make changes in your OR. So this is my my contact info. I thank you for your time and attention. I'm going to move to my reference page. All my references are here. And again, go back to my contact info. And thank you very much.
That was really great. Thank you so much this evening for spending your time and your expertise with us to share. Some of the things were surprising in terms of the 80% of, there are perforations or glove breakdown and we're unaware of it. So I couldn't agree more in terms of the dark underglove. And I put in the chat just to generate some discussion in terms of who works at a center where they do use a dark underglove, because it's great to double glove, but again, you might not see if you have some breakdown there. So really am a advocate for that double gloving. We don't have it where I'm working yet. We do have dark gloves, and occasionally if you can get the right sizes, then it works out. But I'd like to see that to be a standard practice. So I really love what you showed that visual. Very good.
So during my practice, I've always worn contrasting color. However, it was brown, and brown is like skin color. It's better than off-white where there's no contrast, but again, it looks like skin color. However, a completely contrasting color like green, it actually like for those of you who have the contrasting color, you can speak to it. It actually pops. You can see it very obviously.
Excellent. And I can see that there are some members and attendees this evening that are speaking to their clinical practices of their various sites. So many people, I think, do have the routine of double gloving. I think that's pretty much accepted now. And I do see more and more dark undergloves, and the color is, varies from site to site. So I think it is really, really lovely. Double white gloves, maybe brown latex underneath. Yeah. So there is still a variety there. I agree. Blair has said that the holes are very obvious when you do have an underglove that's darker. So thank you for that feedback, everybody. I'm wondering if there are any questions this evening. Would anybody like to post a question in the chat or maybe come off microphone and ask a question if you have any? Try to think about one. I did like also that you talked about the chemotherapy, and one of the types of glove was the neoprene. And did you say at the beginning that the underglove is the neoprene? Is it always the neoprene, or is it a different glove?
Well, at Medline, we have two types of undergloves that are
Right.
green. One is neoprene and one is polyisoprene. We also have a brown neoprene too.
Okay. Okay. Yeah, I like the idea of the neoprene because I work in a cancer center, but just a refresher of the times as well in terms of how what's the maximum at 240 minutes in most cases.
Yeah.
I'd say we probably don't wait that long. We do switch them out before that, but wearing maybe neoprene underneath. It's really hard to have neoprene sterile gloves and keeping the stock for everyone, right? Like, so if we have the green, then maybe double gloving there might be the way to do it.
Yeah, and to be honest, I'm very passionate, and I have to say I was an OR nurse for the longest time, and in the beginning for me the OR was like it's different in the OR. We do things differently, and then as I went older and wiser, and I realized the patient care we provide is different, but there are basic things that are similar to the floor. For example, staff safety. How come on the units, staff wear all the precautions, they know how to handle, but in the OR, we use the same gown, the same gloves, we handle the same way all the patients, even the ones that received chemotherapy the day before. So I want to urge the educators to look at policies in their hospital that are relevant to the OR and start thinking that OR is different, but this policy actually applies to the OR.
Yes, and sometimes it's simply just not flagged, it's not identified. So certainly if you have Epic as your documentation platform, I really do quite like that alert that comes up with a cytotoxic man. That's really lovely, even though sometimes it's annoying, but it is for your safety. So I think that's quite helpful. I'm familiar with that. So that was really insightful for you to include that this evening. Just going to have a little look at some of the comments here. Natalie is asking, we still make our rooms latex free for patients in the afternoon, but as of recently, all our gloves are latex free now at our hospital. Very good. I would agree. We in the Hamilton area, we've gone latex free for sure. And Wendy, I can't remember where Wendy is. I want to say up in Kingston, maybe. We are latex free for all cases, with the exception of a few things. I think there are some things that are still hanging around, like the Penrose drain comes to mind. I think some central lines may have latex in them, but very few and far between. But certainly the gloves have come a long way. And I didn't know Niagara Health isn't latex free. That's interesting, Angela. Thanks for sharing that. Yeah, so I'm not seeing any questions. Any other discussion points that people would like to bring up?
It means either it was very clear.
Very good, very good. And you did mention some things that are a great review for some of us as well. The thing that's the takeaway for me is really that visual with a green underglove. because
Yeah.
it was night and day in terms of the perforation and the ease of being able to see it. I mean, I think you might be able to feel it, but it really depends. If it's only gone through one glove, you might not feel it. So,
Exactly.
um,
Exactly.
and is double glove being taught in programs? I would say it is, Nicole. Nice to see you. I hope you're well. It is being taught as standard now. And I will say we have lots of new OR staff where I'm working. It feels like it's a constant coming and going. But even when I meet with undergraduate medical learners or physician assistants doing sessions for them, we do talk to them about double gloving, and we typically will recommend that you use a darker one underneath. And once they try it, they seem to kind of get it and like it. It's whether or not the facilities they work in have the availability of those gloves for them. Yeah, but for sure it's being taught. It is standard practice for sure. Any last comments? I really appreciate everybody coming on tonight. We have 50 people, including Aline and I. So I think that's pretty good. I think our registrations were in the high 60s. So, 50 out of 67 is really, really good. There's a question from Jessica. Thanks for sending your question. Are the Sensicare SI Shield attenuating gloves made without cerium rubber accelerator?
So they are not made with the accelerator that I mentioned, the MBT and the DPG. I can check if this specific accelerator is made without this accelerator, actually. So if you want to email me, oh no, my email is not here actually. Or maybe Denise, if they have a question that I need to reply to later on, how can I connect with them?
We can actually get a list of the entire chat conversation and then flag that for you. So that's not a problem. Alternatively, I could probably just put your email in the chat. Would that be sufficient?
Yeah, of course.
Okay, I'll do that now. That would be really good. I'll do that before we end this evening. I'll have to look it up, of course, because I'm not the greatest at remembering things. Well, I think we've come to the end. Jessica, I promise I'll put her email in there for you. I want to close this evening by thanking you so very much. I know you missed a dinner cruise tonight in Toronto. Medline's having their national meeting, and Aline stayed behind in the office because the lighting is good. So you look great too. We can see your slides, but missed the dinner cruise. So we really, really appreciate you spending your time with us this evening. And of course, Medline sponsorship. We can't do these things without our vendor sponsorship. So thank you so very, very much. And before I turn off the video record, I'll be sure to put your email in the chat so that anybody who's on this evening will be able to see it. And we can certainly follow up offline in terms of any questions that you still have.
It was a great pleasure.
Thank you so very, very much. And good night, everybody. Thank you for joining us. Stay safe. Good night. Okay, Aline, let me just get your Aline. Maybe you could just tell it to me that way, because I did
Yes. So it's
A
Titi. What if I write it to you here?
No, you can do it. Titizian at
Medline.com.
Oh, that's easy. I'm not one of those people that can multitask. I kind of need to just do one thing at a time. Otherwise, I'll get really distracted. Are you able to see that in the chat to make sure that it's there for everybody to see? Okay, wonderful. I still see 17 people who don't want to get off this evening. Well, that's fantastic. I wish I had another topic for you. Thanks, everybody, for joining, and I'm sure we'll be in touch. Thank you once again. Good night.
Good night.
Good night.